Morning, guys. I took a note out of Jesus's book, and I did a second part to my last year presentation.
Nice.
So, it was an easy follow-up for myself. So
now I have to go watch the first one.
Yeah. So, but in case, that was a great question that you were wondering. So here, let me tell you what exactly I talked about last time for their benefits. So these are just a couple of the articles I did last time. Post-exposure doxy, talked about that. Talked about Cape Cod trial, hydrocortisone and severe cap. Then did like a review article on like early lead extraction for cardiac devices, device infections. Picked one specifically for Dr. Canala, for dependent patients with hypoalbuminemia. This fifth one was pretty interesting. It was post sign-off events after ID consultation, and we signed off. And so that was a non-adherence to ID recs after we signed off. So that was pretty interesting.
Nice.
So it was a lot. There was a lot of good debate last year. And then we talked about like new antibiotics and why ID specialists don't really like to use new antibiotics. They like to be stewards. So I don't have as many articles this time. So last time took a long time. I learned my lesson and I picked a couple less. So hope you guys kind of find some of this interesting. All right. So this is how I'm starting off 2023, hottest year on record so far. And so the article that I first one that I'm starting off with is this NEJM article. Let me bring this down a little bit. Kind of looking at, waterborne diseases and how climate change affects them and how it's going to affect what we're going to be seeing and the prevalence of certain types of infections in the coming future with climate change. All right, so this is from the WHO General, pretty interesting quote. Modern addiction to fossil fuel is not just an act of environmental vandalism, but from a health perspective, it's an act of self-sabotage, which I think we're going to be dealing with as we go into private practice in the future. So something or any type of practice. So it's something that we need to be aware of in terms of these changes. So this article does a pretty great job. So first it kind of starts off with like key climate change drivers, talking about fossil fuels, deforestation, land use, agriculture, climate hazards, increased ambient temperature, precipitation, floods, droughts, sea level rise. And then it goes to how it affects certain pathways in terms of contamination and overflow of sewers, how it affects pathogens, replication, survival, virulence, contact with floodwater, sewage, disrupted health surveillance, water sources, and I'll get to specific examples about that. I think it's pretty well kind of documented in terms of the relation between bacterial diarrhea and the prevalence during warm summer months. Like Salmonella campi have increased survival and fitness in warmer temperatures. So that's a prevalence that's going to increase with time. With the hot weather, there's also going to be increased drinking demand. People are going to want to drink more water, and the other issue is if there's drought, there's going to be less water for people to wash their hands and things of that sort, and that we'll get into as well. So sanitation is going to play a huge role, no matter whether it's a low income area or a high income, industrialized area, it's going to kind of affect both sides because nobody's really prepared for, these weather extremes that'll probably come up. And if anybody has anything, comments or anything, just jump in whenever. So they do a pretty cool thing where they go basically, by specific pathogens and say how these environmental effects affect these specific pathogens and, what we're going to see. So I'm not going to read all these things that are here, but I'll just kind of highlight some of the key things that they brought up. So, for like we talked about Salmonella, Shigella, Vibrio, they have increased survival and reproduction in warm water. So prevalence is going to go up, pathogen burden is going to go up, exposure risk is there. Salmonella, Shigella, they actually have virulence genes that have increased expression in higher temperature, and they're repressed in lower temperatures. Things like rotavirus, noro, cryptosporidium, giardia, they will have at increased temperature a bit of a higher die-off. So their actual burden might come down a bit. So we might not see as much in terms of the clinical setting. Things like Legionella, that with these higher temperatures, they'll have increased survival in biofilms on ACs, water filter systems. So prevalence will likely go up in the future as well. This slide, so this is like a full chart. The initial one was just looking at temperature and how that affects these organisms. Then it goes to precipitation and flooding. And then it also talks about drought and like storm surge and sea level rise. So with precipitation and flooding, the issue is compromised wells and portable water system sources. So with things like leptospirosis, staph, hepatitis A, rotavirus, with increased precipitation and flooding, you'll just have more of these pathogens coming down and, infecting water sources and coming down in floods and such. There's like a lot of water treatment failure and contamination, things that have happened in the U.S., U.K., Europe, so it's not just, like I said, resource scarce areas, it's resource rich places too. With drought, there's going to be insufficient treatment options, decreased hand hygiene. So this will increase fecal pathogens. The other thing with decreased water in the water lines, there's not going to be as much pressure in the water lines, so there's higher risk for exogenous contamination of the water lines itself. So that risk is there. With things like storm surge and sea level rise, I mean, we see it here in Tampa, hurricanes in Florida. Pathogens can contaminate drinking water due to storm surge. Big, easy kind of example, Hurricane Katrina in 2005. After that, there was a huge Vibrio outbreak due to wound exposures from the floodwaters. Then Cyclone Idai, I think in southeastern coast of Africa. There's a huge cholera outbreak after that. So these are like real life examples that, as the severity of these systems kind of increase and the frequency increase, that we have to kind of be worried about. And they also have some cool pictures. I always had attendings talk about cool pictures, and I never realized why they liked cool pictures, but then I started liking cool pictures too, and now I realize. So, these, they go by like, they have a couple of them. They talk about crypto, Vibrio, and then leptospira in the next slide. So, crypto, as we know, lifestyle in a single host. Oocysts excreted can last for months in like moist soil and water. In '93, so kind of right after I was born, there's huge severe rains in Milwaukee, and that actually contaminated public water system. And there's a huge crypto outbreak back then in Milwaukee. So these are like real life examples that I kind of want to bring up so that we know it's real. Here we have Vibrio. It talks about the increased global temperature, increased sea surface temperature, increased pathogen burden in the water and exposure. So the northernmost outbreak of Parahemolyticus specifically was in Alaska back in 2004, and that was due to increased water temperature, ocean temperatures, and oysters got kind of had an increased pathogen burden, and people got subsequently exposed. So Vibrio vulnificus specifically is expected to kind of be all there throughout the eastern kind of seaboard by what they're saying is like 2070, 2080. So that's just going to increase, and that risk is going to be there. So it's not going to be very specific. Just like we worry about like people traveling from place to place and bringing pathogens, these climate changes can kind of change the where we see these usual infections. So here's Vibrio cholera and then leptospirosis. So lepto, as we know, kind of seen in the urine of infected animals, including rats. So, they can cause fever, muscle aches, headaches, Wheals disease. We know kind of the clinical manifestations. Actually, where my parents are from in India and South India and Kerala, they had like huge floods back in like 2018, 2019. And there's a huge outbreak of leptospirosis because people are walking in the flood water and they're getting exposed like that. So this is another thing that we need to kind of keep in mind, especially depending on where we kind of end up in terms of practice. So they kind of talk about things that we could do or things that should be done to kind of mitigate these risks of these pathogen exposures. This wash system that of course, they talk about greenhouse gas reduction, using energy efficient technologies, renewable energy, water conservation. They talk about this wash system, which is like a system kind of focusing on like good water sources, sanitation, hygiene. The risk is that there's a lot of urbanization going on in like low and middle income areas, so they're not able to kind of adapt and have proper sanitation and housing for people. So that's with the population increase, it's kind of tough to kind of do these two things at one time. So and higher income countries, the lower income communities in those countries will probably be impacted more just because of infrastructure issues, like antiquated water systems. And an example of that is the Legionella outbreak in Flint, Michigan in 2014. So at that time, they had to change a water source and temperature, and they had to use an old water distribution system, and there was increased iron that kind of came out from the pipes into the water, and there's a Legionella outbreak from that. So that's kind of like a real life example of one of the issues there. So medical interventions that we kind of do. So, educate the clinical and public health workforce. People need to know about these things, and early warning systems. So this is a pretty cool, this picture over here. So this is from the European Center for Disease Prevention and Control. It's a Vibrio map viewer. So they kind of try to predict climate suitability for non-cholera Vibrio. They sense in real time like water temperatures and salinity, and they try to give like a 5-day forecast on where there's going to be an increase in pathogenic Vibrio. And they send public health alerts to the public, and they have a system where they can send it to actually at-risk individuals. I'm not sure how they get that information out there, but they let them know not to eat oysters or go out in the water, and they close certain water areas off, beach closures. So pretty interesting. I went up to the website, tried to mess around with it a little bit, but yeah. So that's these are kind of the things that probably need to come into play a little bit more in terms of the public health aspect of things. And of course, trying to transition or try to make a seamless transition from fossil fuels, which is much easier to ask than to do. So that is that for that first article. Any questions, concerns? Hope you found it interesting. So next one. So I only did one trial in this presentation, the ProPhi-VAP trial. I was going to do Sabato, but Kirtan beat me to that one. So there's been a lot of, I think there's the amikacin trial that came out for like preventing VAP in intubated patients. So this one was a ProPhi-VAP trial that came out that was published last month actually in Lancet. So this one is where it's a multi-center randomized double-blind, placebo-controlled superiority trial that was masked, done in 9 ICUs in France in 8 French university hospitals. So they're trying to see if a single dose of ceftriaxone would decrease the incidence of VAP in patients that are intubated and they had a severe secondary to severe brain injury.
Just one dose?
Yeah, just one dose.
Interesting.
Yeah. So, previous evidence, there's been a lot of trials. I didn't include the amikacin trial that came out a couple months ago. They have the Antarctic trial. Here they used 48 hours of amoxiclav for patients intubated after cardiac arrest. There was some reduced early onset of VAP, and of course the political answer of trending towards ventilator-free days. Then we have the second trial. I'm not going to try to pronounce it. So here they tried to selectively decontaminate the digestive tract with IV antibiotics, which is either ceftriaxone or Cipro, and then give oral antibiotics to critically ill intubated patients and kind of decontaminate their digestive tract. And and I already know I had the same reaction as you guys. So of course there's overall neutral findings, but they did a post hoc analysis and they saw in these brain injury patients, there's some reduction in mortality, improvement in ventilator-free days, hospital-free days, and free days. So in this trial, the design-wise, so the patient population, they were intubated for airway protection in the setting of head trauma, stroke, or subarachnoid hemorrhage. Inclusion criteria: GCS less or equal to 12. Predicted to be on the ventilator for at least 48 hours. No ongoing antibiotic therapy. Absence of an active infectious process. They weren't intubated for greater than 12 hours, and they hadn't been admitted for greater than 48 hours. So they received a one-time 30-minute infusion of 2 grams of ceftriaxone or saline, and that's how they kind of split it up. Exclusion criteria: anyone with cardiac arrest, previous hospitalization within the past month, a trach or a beta-lactam allergy. They were assigned 1-to-1. There was already implemented, VAP preventive measures in the ICUs, but they weren't monitored. So I don't know how adherent these ICUs were to things like hand washing, having the head of the bed at 30 degrees, the usual things that can be done or that should be done in the ICU. They used the ATS definition for VAP. And then primary outcomes was proportion of patients developing VAP. They did 2 to 7 days of mechanical ventilation for early VAP is what they kind of defined it as. Secondary outcomes, whether the patient was in the ICU at day 28, discharge, VAP after 7 days. They looked at the type of organism that caused the VAP in those patients that had it. Antibiotic-free days. These were interesting. Digestive acquisition of ESBL-producing Enterobacteriaceae. And we'll talk about how they kind of tried to monitor that in these patients. So real quick, they had 319 patients. Majority of them, 49%, were intubated for subarachnoid hemorrhage. The study power was 90%, two-sided type 1 error of 5%. So result-wise, the rate of early VAP was lower in the treatment group, 14% versus 32%. P-value is 0.03. There were statistically significant improvements in ventilator-free days, ICU-free days, and hospital-free days. The mortality and neuro endpoints were improved at day 28 for the treatment group, but when they followed up at day 60, there was no difference. So, antibiotic resistance, they call us sometimes the police, which is an unfortunate way of describing us, but it's that these are the questions that come up. So stewardship-wise, the interesting thing was ceftriaxone, in this study did increase the number of antibiotic-free days. And we see VAP is often treated with vancomycin or vancomycin. So if we're able to kind of prevent some treatment of VAP, that's less exposure to higher broad spectrum antibiotics. As we know, VAP usually treated for 7 days, but ICUs, people don't usually stick to shorter regimens. So, there's that. The other thing, so there was no difference in C. diff or ESBL rates, but how they tried to, detect this digestive acquisition of ESBL, they did rectal swabs on the patients and tried to grow it out. So that's very... It wasn't the most accurate in defining that, yeah. So the other interesting thing, VAP in the placebo group, resistant organisms were rare. They only had like 1 MRSA VAP and 1 ESBL related VAP, and our patient population is nowhere near that. So I don't think it's very we can't really say this is the same patient population. So. Couple of suspect things that came up when going through this trial. So I don't know if this is something that we'll probably see in our ICUs. I don't think it will. I don't know if it's as attributable to our patient population. All right. So my third article that I'm going through. So this one was one that came out with in CID, and this one I thought was pretty. For us, especially with some of the patients that we see, especially at Moffitt, where we see a lot of these malignant abscesses, intra-abdominal abscesses being in tough situations, I thought it was a very good article to kind of go through. So this article kind of navigated the use of antibiotics at the end of life. And, antibiotics can, at the end of life, it's always about life prolonging versus kind of comfort. And antibiotics can kind of go into both, areas depending on how you say its job is in that situation. So this article really focuses on like our role and what we can do to kind of help in the situation and kind of help ourselves in terms of like stewardship and the message we want to get across to patients. So, they talk about, setting expectations early on in the disease course, kind of updating the family in terms of like this disease trade-offs and side effects and things like that. And, they have this remap kind of outlook to kind of address patients, looking at like reframing the situation, talking about emotions, talking about goals, planning out next steps, and then aligning the goals with what the family wants. So I think what they did was pretty cool. They set up a patient scenario that they talked about different steps of this patient and, how we would kind of address things. So this is a 67-year-old lady, recently diagnosed with unresectable cholangiocarcinoma. She started on chemo, developed fevers, weight loss, right upper quadrant abdominal pain, got admitted to the hospital, started empirically on Zosyn. She had CT abdomen done, and that shows several rim-enhancing fluid collections in the liver. Had a percutaneous drain place, and the culture grows Enterobacter cloacae complex, and we're consulted for Rex on antibiotic on discharge, of course. So taking a closer look. So, definitive drainage, often not curative in malignant obstruction, which we know. I think the main thing is patients should understand that the infection is due to this malignancy that's there, and it's not the main issue here. So I think, one of the things that they talk about is, patients and other physicians, non-ID, they think, automatically infections are all curable. But in these cases, these are recurrent issues. There's no real source control. And that's one thing that we have to be better about letting the families know. So, we have to talk about, treatment duration, ongoing monitoring when the antibiotics are, held, and kind of keep the family and the treatment teams updated on this. And then, of course, there's complications. Nephrostomy tubes getting infected, biliary stents getting infected. It's a lot of things going on at one time that we are the ones who have to kind of keep in mind. So, the patient was eventually discharged on cefepime, developed some intolerance, was switched outpatient to oral Bactrim, but developed nausea, vomiting, had to be readmitted to the hospital for dehydration. The biliary drain is replaced, 2 new drains replaced, and then cultures are sent from the new drains, and ESBL E. coli is grown. No good oral options for him, so sent home on ertapenem. Next couple of months, having issues with antibiotic tolerance, on and off antibiotics, in and out of the hospital due to recurrent abscesses, kind of a story that we've all seen, very often. Multiple consultants agreed that source control is impossible, which we were probably saying from the beginning, but, it's good to have everybody on board. So, at this point, it's like letting the family know that the goal of antibiotics is to control the infection, not cure it. They've already been through, this patient's going through all this. And I think at this point, what they kind of say is, even though infection is not the underlying disease, that infection may be the reason that the patient dies. And that's like the thing that they need to know. And, controlling is all that we can do from our end. So, the patient goes back home and then comes back from being altered in AKI, was having hypotension at home, admitted to the ICU for septic shock. Started empirically on vancomycin. Blood cultures grow Candida, started on Caspo. The oncology team at this point is saying chemotherapy is unlikely to be continued due to deconditioning and patient's comorbidities. Family agrees for hospice at home and requests to continue the same antibiotics at home. So this is a situation that we get put in. And so they propose a couple of different ways to kind of address this, kind of talk, if hospice at home is the kind of goal for the family, continuing IV antibiotics is going to make that tough. It can complicate the discharge. They can miss that safe transition period to get home just by having to set up antibiotics. Then they bring up this time-limited trial to bring up with the family, which is like, agreeing on markers of patient improvement that the family can actually see, which is like fevers, vasopressors going down, oxygen requirements going down, and then setting a time to reevaluate whether the antibiotics are working, 1 to 2 days. 2 days, if things haven't improved in that time, then we have to talk about, withdrawing antibiotics, de-escalating, or maybe doing another trial. Just giving those options and, kind of setting that time, because if we don't have the conversation, then things are just going to continue. And, we've seen it all too often. But I thought that was pretty, I thought that was a good idea from their end on what we could do just to kind of limit things, even if we can't put an exact time on de-escalating antibiotics. So, the patients ended up having a time-limited trial, did not respond. Decision was made to proceed with comfort measures in the ICU. Patient ended up passing away in the ICU after vasopressors were titrated off. Caspo eventually was taken off the Vanc marrow just on the Caspo function. That was continued until the day of death. And the thing here is, earlier goals of care conversations, they could have been home, could have been home with hospice, which is what their initial goals were. So, it's really important for us to align patient goals with our clinical expertise, because that's the whole reason why we're there. And they actually talk about a study where, 82% of patients with metastatic solid organ cancers remained on antibiotics, within 2 days of passing away. So, that's one thing that was pretty eye-opening, but that we see pretty often. So I thought that was a really good kind of review especially for us, because we end up getting stuck with these conversations because sometimes conversations are not had or appropriately had. So we end up being the ones having to do it. So, I thought it was a good kind of review for us.
Did they make any suggestions? Because I noticed in that timeline that it took several interventions before finally said, hey, maybe we're not going to do chemotherapy. It seems like one of the barriers to kind of discussing early with the families being like, hey, you're going to keep getting this infection from this obstructive tumor or what have you. That one of the barriers is the promise that if they can just get a little better, they'll get chemo.
Yeah.
If they get chemo, they can live longer.
Yeah.
So did they address that at all about getting other teams buy-in to manage those expectations as they relate to infection begin?
So they played a very political. What they were saying is, they kind of even worded it. ID physicians often get frustrated, but we should try not to be frustrated in front of the patient. It should be outside the clinical setting. So
fair enough.
That's an issue in and of itself. That's kind of contributing to it too, because these conversations need to be had when it's a non-curable malignancy, and they need to know that. So, but they didn't talk about it specifically.
I see.
Yeah. So they want to ruffle any feathers.
In what scenario would antibiotics be a comfort care medication? Maybe like if you have a urinary tract infection.
Yeah. So they specifically lay out. Yeah. They specifically lay out certain scenarios and they talk about urinary infections in a hospice setting and being on oral antibiotics just to kind of relieve the kind of symptoms that they're having. So I think in those cases, it's most where I don't know if it's data, but
If
an infection that's clearly curable,
exactly.
and that's causing the patient some discomfort.
Yeah, exactly.
Otherwise,
a lot of hospices won't provide antibiotics at home.
No, they won't. They won't pay for it.
They won't pay for it. So,
or should they? Well, and that's the thing. Like in this particular scenario, they should have kind of been discussed at the beginning.
Yeah.
Where it's okay, we could offer this trial, but that's 48 hours that's going to prevent you from, which is exactly what happened.
Exactly. Yeah.
So,
and we see it often. I mean, when the decision's made, they end up being too sick to go back home.
And I'm you're never going to make it home. So, which is more important to you, this trial of 2 days that's probably not going to work, or going home and dying there.
Yeah.
So.
Because even if the infection is causing the patient discomfort, we have medications that
to alleviate that.
Hospice that are there to alleviate it.
Yeah, those symptoms.
If it's a pneumonia, we have medications to relieve respiratory issues.
Yeah. Well, I think oftentimes the issue is the family and the patient think that we take care of the infection, it'll fix everything else,
Right.
you know, and like,
Right.
you know, leave things, and they don't have that.
Yeah, well, it's the same thing when they try to like force feed patients, where if you just feed them,
Yeah,
then they'll get better. And I'm just
Maybe they
like,
won't aspirate less.
yeah,
you know, but that's the thing. It's like you have to unfortunately have everybody on board. I feel like, especially at the beginning of these things, there's always that, you know, I don't think the teams are getting on the board at the same time. We may recognize it as this, you know, part of his lung is choked off by lung cancer. They're not going to remove it.
Yeah.
You're going to keep having a post-obstructive pneumonia. You're going to keep getting the empyema.
yeah,
And we recognize that and we vocalize that. But then you have other teams that are probably like,
yeah,
yeah, once the infection's clear, we can start this. You
yeah,
know,
exactly.
insert whatever here. So I think that they hold on to that for a very, very long time.
Yeah.
And then, so they're always going to think that, oh, if we could just get this, then the fever will go away. If we could just get this,
Yeah.
So then I think after a while, it becomes hard to wean them off of that. So they see somebody that's in pain or having a fever, having a cough, or having trouble breathing. And instead of going, this is the disease process, you know, this is your lung cancer getting worse. It's like, oh, if we just throw a little pneumonia juice at it, then they'll breathe better and then they get their chemo.
Yeah.
No, that's tough.
Yeah.
They're right, but we just need buy-in.
Yeah, I don't think we do a great job of having these conversations sometimes.
Yeah.
We sort of leave it up to the palliative care team.
Yeah.
Yeah.
But
And
I think that's the issue.
Yeah, and like they don't have the same rapport
Exactly,
necessarily that like the longitudinal care team.
Or even understanding in terms of the infection. Like,
Right.
they
Right.
don't- yeah. You know,
Yeah,
that's the
I-
issue.
Or sometimes they see them once.
Yeah.
And it's like full
Full court
scope
press.
and, okay,
Yeah.
so no.
Yeah, exactly.
It's like you gotta build
Need
some.
discussion.
Yeah.
No, I mean, and we can't. I don't think we put too much blame on them either, because they can only do it in the context of what's going on at the moment.
Right.
But I mean, I think it's up to us to discuss and maybe be a little less diplomatic.
Yeah,
You know,
I agree.
it doesn't necessarily have to be to the patient's face, but in our notes and our communications, being like, "Hey, dum-dum, this infection's not going away."
Yeah.
Yeah,
So-
this is what's happening.
You keep
Like, this is
keep
the
saying in
reality
your
of the
note,
situation.
yeah, you keep saying in your note, chemo. I'm telling you right now, this is never going away. If
Yeah.
you need an afebrile patient to do chemo, you're never getting an afebrile patient. So good luck.
Yep.
Like the surgeons have said no, we've said it's not going to happen, so maybe reevaluate, reassess. So
You have to tell people the truth.
you have to tell
Right.
patients.
Yeah.
It's not comfortable sometimes,
Yeah.
and it's, you know, and they can take that out on you,
Yeah.
but it's important that they know
Yeah.
what's going
what's
on.
going on in the treatment. And I feel like
The reality of
sometimes
the
it's limbo.
situation. Yeah,
I
exactly.
don't know.
Yeah.
No, for sure. And I can see why patients would get confused and why they would cling to false hope, because they're getting mixed messages.
Yeah.
So that's the thing. I think that communication, we just maybe need to be a little more firm with some of our
Yeah.
colleagues and be
Yeah.
like, listen, we're not going to get to the time where the tumor is small enough where we could resect it out.
Yeah.
We're not going to get to the point where they're going to be on their 5th line of chemo. Just be like, you think this is going to go away, but it's not going to go away.
Yeah, exactly.
I think in reality, these conversations require like a multidisciplinary,
Has to be.
because you can tell the patient the truth from
Mhm.
your standpoint, and then, like you mentioned, like you guys mentioned, the next person comes,
Yeah.
says
Yeah.
something different.
Yeah.
They will forget what you discussed,
Right.
and they will hang on to any bit of
Right. It
Yeah,
does
exactly.
everything every day.
Yeah.
its cultural nature of human beings to, you know, grab them to whatever little hope they get.
Yeah.
Well, and that's why back to your point, having palliative stay on board would be helpful,
Right.
because I think
Yeah.
they should like analyze the patient by themselves and also talk to the team at large. It doesn't have to be like a full-fledged family meeting, especially if they're still like, if the family is still, you know, delusional and full court press, but it'd be nice to at least have a definitive understanding and charts that definitive understanding of what the disease process is, so that when new teams come on or they go to some shady place in Mexico, or, you know, they're reviewing, oh, this, that, and the other thing was said, at least they're on the same page, and those doctors could be like, no, actually, the team talked about this, and they said, and they communicated to you, this is what actually happened.
Yeah.
This is what actually was going to happen. Now that has come to reality, so what they told you 3 weeks ago is still true.
Yeah.
So I don't know. It's complicated, but I think that sometimes our craft and everybody else's craft intersect, especially in the cancer setting. the old joke is true.
Yeah.
You're gonna nail the coffin shut.
Yeah, no, it's true. Yep. All right, guys. So I have one last one. All right. So what's 2024 article review without talking about AI? You know, for a little bit. So nothing too crazy. So I don't want Will to get too annoyed, but I have some relevance that's coming for all of us. So here we are. So this is a NEJM article that came out on understanding liability risk once healthcare starts to be implemented into the healthcare setting. So they looked at kind of different cases, court cases that came up regarding healthcare issues or litigation that came up with software error. And they were trying to kind of extend it out to AI because there hasn't been a lot of AI. Yeah.
There are that many.
Yeah. No, so it hasn't been extended out. So they're trying to kind of predict, this may be where things go in the future. So the tough thing is AI is all, mathematical equations that, they look at statistical patterns with all the info that they're getting. So there's no like preset kind of code or something that they can kind of compare to. So that's the issue with AI and litigations and how we might, kind of get affected. So they looked at like 51 cases of software-related errors causing physical patient injury. I'm not going to go through all of them. I'll just kind of talk about one quickly and then kind of talk about, how we need to think about things. So this specific case was a case Sampson versus Heartwise Health. So what happened was these cardiologists, they used this software program to do this cardiac screening for this young patient who had a family history of congenital heart disease. And I guess the cardiac screening software or the software said the patient was not at risk. So, they gave him a clean bill of health. And I guess a couple months later, he ended up passing away from a fatal arrhythmia. And then the coroner's office said that he did have a congenital heart defect. So then, the family sued and, sued the company and then sued the physicians. And that's, kind of one of the things where, software, errors or outputs can affect treatment decisions. And then, the physicians can be affected. Where the physicians, what they were saying was they should have ignored the recommendation from the software or should have came to the right decision on their own accord instead of trusting the software. And that's the issue, as AI or, gets slowly implemented into EMRs, the risk that comes about. So they talk about, assessing liability risk with healthcare AI, the inaccuracy of the model output. It's only as good as what goes in. So that's the issue. So, as things get updated, practices change, they need to make sure that these models are getting these up-to-date information to put out accurate, output for people to follow, if we decide to follow. So they talk about, quickly, just like, how to litigate, how to assess when a bad outcome comes out, the liability risk for physicians and healthcare providers. So, the way to mitigate these risks is, AI, all these developers are trying to get into the healthcare system. It's a huge, business opportunity for them. They're trying to jump in. So healthcare organizations are a buyer's market. So they need to kind of ask for, effective risk assessment and monitoring. They need to have early warning signs for system errors. They need to negotiate, favorable terms for liability insurance and risk management, where the hospital, the risk is mitigated and physicians and the providers don't have as much risk either. So, there's going to be things like AI specific insurance that's going to come out, and that's another money making scheme. So all this is in the works. So, in terms of us to keep an eye on. So this is Epic's EMR strategy for 2024. So this is what they're planning on doing. So they're planning on bringing AI to summarize, patient charts, draft responses to patient messages, and they're also developing ambient listening, which is, where they're listening in real time to what's going on, and they're writing these notes, for us as it's listening. So these are all in the works and things that we need to be aware of because it's going to be big changes. And then, of course, online we've seen all these chatbots and, these conversations with chatbots on different websites. they're trying to do that same thing into the EMR system. So, I'm not sure if it's going to start jumping into Epic Chat with all of our messages that we have to respond to, but this is what they're trying to do to streamline communication. Then they're going to try to use AI to, to kind of optimize, hospital beds and operating beds in the hospital, because dollars and cents, it's all about making efficiency. And then they're, what they want to do also is have, like, say we're going through a chart and then we're like, oh, I wonder how many people have done this, or the data behind this. They're trying to set it up where it's like, you can just put the query, or speak into the generative AI, and it kind of does a full search for you, and in terms of medical data. So those are things to keep an eye on, and changes that are coming our way. I know Dr. Sinnott always talks about AI, but I think that I saw this Epic EMR strategy, and I was like, these are things that are interesting. Yeah, interesting, and probably going to affect our, how we deal with EMR, and it's better to know these things early than be caught off guard. So keep an eye out for these things. Nice. Very interesting. All right, thank you.